So if people have a wire put through their artery to open it up, do they always have to have a stent? Why does the artery kind of collapse? What happens?
This is such a great question because you don't always need to have a stent. And there are some doctors that have been in the business for a very long time. There are even some that may have just graduated, from university and their fellowship, and they're just used to stenting. It's just part of the training protocol. They have to place a lot of stents to really learn how to, get them in there properly. And important. It's definitely an art, right? As much as it is a science to be able to do that. So they have a lot of practice and they fall back on what they
Back on
know.
what they do.
But the new philosophy when it comes to stenting is less is more when it comes to the legs. If you're going to have a heart cath, if you're going to have your aorta opened up, if you're going to have your iliacs opened up, all in your abdomen there, the stents are usually a guarantee. It's an They're areas that stents don't seem to block up as quickly. When it comes to the legs, which are moving all the time, the stents do close up very quickly. And there are a lot of reasons for it. The number one reason is that anytime you put a foreign object inside your body, it's going to trigger a healing response. And some people, especially when you're younger, you're going to have a quicker healing response than someone who is older. So the key is making sure that you understand the reason that you're going in and the reason you're having that artery opened up and the reason you're having that stent potentially put in there to make it last just that much longer is so that you get enough relief so that you can get out and walk more, further, and faster to grow your collateral network of vessels. So when that does close up, and it's not a matter of if, it's usually a matter of when, because of that healing response, you may not need another procedure at least for a long time because those collateral vessels have grown and they're able to feed your leg with enough blood flow. Now, that being said, another reason that we've seen these stents block back up so quickly and is because they're not sized properly. And what happens is in many cases is the doctors are just relying upon a 2D image and just their eyes and feel and experience to be able to properly size and place that particular stent. And it's not 100% accurate. So we have patients, for example, that have had stents placed in their iliac arteries. And that is the place I said that it's more durable, right? And that's why you pretty much, if you're getting your iliac arteries done, more likely than not, you will get a stent placed. But they may not be durable because the doctor did not size that stent properly. Might have put a stent in there that's too small or too big. Usually, what we see is that they place a stent that might be too small in there. And so it just keeps blocking up. We like a doctor that goes in and uses a device called an intravascular ultrasound or IVUS. And it uses audio waves to give the doctor a better idea, a more accurate idea of the morphology of the plaque. I love that word, morphology of the plaque, the type of plaque. I love when I get a doctor that calls me and says, one of your patients, I had to talk to the person that taught my patient the word morphology. I have never in all of my years heard a patient use the word morphology. And I love it because I just think it's fun. But you're just basically talking about the type of plaque that's in there. Or do we have clot? Do we have fibrous material? Do we have rock hard calcium? What type of plaque is in there? They can really get a good idea when they go in with this IVUS, intravascular ultrasound. The other benefit of IVUS is the fact that they can better size the vessel to be able to choose a more accurate size of stent to place in there, right? And so that being said, we're going back to the less is more approach, and with the thigh and with the knee and below the knee arteries, usually doctors are erring towards less is more. And they realize that if they go in and they don't do a lot of trauma to the vessels, meaning going in there and pumping the heck out of that balloon with high inflation rates and that kind of thing, and taking their roto rooting devices, the atherectomy devices, and instead of just kind of going in there, maybe burrowing a hole through, maybe taking a couple passes with that device to sand it down a little bit or laser it a little bit. Instead, they're going back and forth and trying to do what's called, maximum luminal gain, trying to get as much of a pathway through there as they can. And, that could traumatize the vessel even more and trigger the healing response much quicker. And you have a greater chance of damaging the vessel, perforating the vessel, dissecting the vessel. And in those cases, yes, you need a stent. And so I always say go in, tell the doctor, what, I want a less is more approach. If you're treating, I tell people, know where your blockages are before you go in. So you can have this productive conversation with them and say, in my thigh, is it possible for you to just go in, tiptoe in, take a less is more approach? If you feel like you need to take out some of that plaque, let's say it's rock hard calcium, the orbital atherectomy device is indicated for rock hard calcium. So a doctor can go in and maybe sand down a little bit of that plaque, which makes it more amenable for the balloon to be able to expand just a little bit more. They call that preparing vessel preparation. And that's mainly how we think that these atherectomy devices should be used. There are also other types of these vessel preparation devices that are actually making it so they can use fewer stents. And one of them is a lithotripsy device. And they use those sound waves to just crack the plaque. And then they follow up with a drug-coated balloon where the drug can seep into the little cracks in the plaque and get closer to the vessel to soothe the vessel. And they're actually cancer drugs, paclitaxel, and the other one is just escaping me right now. It's a newer one, but it actually is making it so that the vessel won't trigger that healing response as quickly. So maybe a stent may not be needed in those cases. So it's not a matter of if those stents are going to block, it's a matter of when. So if you can work with your doctor on a less is more approach, I think that's always your best bet.
Yeah, so it sounds like they don't have to be completely open, do they? They just have to be a bit open,
Right.
right?
You need literally just that much more flow
Mhm.
in order to get you that much relief so you can get out and walk and grow more collateral vessels.
Yeah, yeah. For me at the minute, I was told by my surgeon I could make it a little bit better. That's what he said. Well, I've done that, you know. And so now I'm thinking, okay, what else can we do? Because I'm still limited in what I can do. And so I'm going to see this other surgeon that you recommended, bar the man in London. And in a couple of weeks, going to have to talk to him about it. And he's also being quite nervous about it and saying, well, it depends. And as we all know, as soon as you touch an artery, you're going to damage it in some way.
Yep.
But I'm going to see him and we're going to see what we can do. But like I'm sure for everybody here, when you've been in a really bad situation, if they can make it even just a wee bit better, you feel like, oh, it's fantastic. And so I'm still hopeful. Maybe there's something possible, but it's great. All these things you're saying, Kim, I can go and talk to him and understand, okay, what's possible, what isn't, and also manage my own expectations about what's possible, in fact. So it's grand. So I really appreciate what you do, Kim.